Hi, I'm Kendrick Johnson. I'm a third-year medical student at Toro University, Nevada, and this video is aimed at third and fourth-year medical students looking for a quick overview of common arrhythmias. This is based on review materials, so it's intended for a review of common arrhythmias in preparation for step 2 of the boards or step 3 of the boards. So, common arrhythmias are atrial fibrillation, atrial flutter, multifocal atrial tachycardia, supraventricular tachycardia, which encompasses some of the others we talked about, Vtach and v-fib. And just as a brief overview, I wanted to talk about from a primary care physician perspective, what are some basic guidelines for sending people to the ER? You know, some of these rhythms can be handled in your office, but you want to have some guidelines of when to get the people out of your office and somewhere where they can get a little bit better care. So, any person with an arrhythmia with new syncope or near syncope that you don't know how to deal with, you want to send to the ER probably right away. Sustained wide complex rhythms other than a known bundle branch block, those are people that should go to the ER. If you just don't know what the diagnosis is and the symptoms seem threatening, it's pretty much a no-brainer. And patients with heart disease that present with new symptoms. And if you have a supraventricular tachycardia that you can't break with some of the ways that we'll talk about in a minute, and Afib or flutter with rapid or slow rates. Also, if this is an emergent situation, so these people have stable vital signs and are relatively asymptomatic, but they're candidates for getting a pacemaker or for any type of antiarrhythmic drug. Up to date suggests that antiarrhythmics be handled completely by cardiologists. Of course, that section was written by cardiologists, so I don't know if there's a bias there, but for me, I think I'll be happy to send all those out to a cardiologist to take care of. And then any kind of a catheter ablation procedure or a pacemaker, of course, you're not going to be doing those in your office. So, but if you think that your patient could benefit from one of these, then you want to send them to a specialist. So, Afib, when I think of the causes for Afib, it's easy for me to remember because I happen to be extremely frightened by pirates. So, pirates make my heart shake. And so pulmonary disease, ischemia, rheumatic heart disease, anemia, thyrotoxicosis, ethanol, and sepsis. That spells pirates, and those are some of the causes of Afib. So there's two ways that these people will present to you. One of them might just be you'll see it on an EKG and they didn't know they had it. They might be having some vague symptoms, or some people are doing screening EKGs, and you might pick something up like this. But some people you might be working up for chest discomfort, palpitations, hypotension, syncope, tachycardia, and so you run an EKG and you see a very characteristic wiggly little line with no discernible P waves and an irregular rhythm. So that's pretty much diagnostic for Afib. Some complications, the complication of Afib is emboli. So what happens is you get this turbulent but low flow area in your atria, and that's a great place to create clots. And if it's the right atrium, you're going to get a PE. If it's the left, then you can get a stroke. So that's the main reason that we worry about it, and the main reason we treat it especially with anticoagulation. That's going to be what most of your Afib patients are going to be on. But you also use beta blockers, digoxin, and calcium channel blockers for rate control. And if we catch it early, then that's when we start thinking about cardioversion. So procainamide or sotalol are used for medical cardioversion, and you can also do electrical cardioversion. But what do you want to worry about when you're doing cardioversion? Emboli, of course, because if you have this clot that's sitting in your atria and the atria has not been contracting, then we suddenly start squeezing it again, and we start squeezing these clots out, and they go to your heart, or they go to your lungs, or your brain. Of course, they could go anywhere else too, but those are the areas that'll kill you the fastest. So the angry brother of AFib is it's going to look like it, at least in symptoms and a little bit on the EKG too. Differences on the EKG is we're going to have a little bit more of a rhythmic look to the P waves, and this is going to be a little bit slower of a rate, so under 300 of an atrial rate. But though the atria are conducting a slower wave, or a less frequent wave, we're going to get more frequent ventricular contractions, because more of those atrial waves are going to go through and cause a ventricular contraction. So some of the complications with this include the emboli that we're worried about with the Afib, but we also can get ischemia and heart failure because your heart is working really hard. And the treatment is similar, but this is not going to be the type of thing that we just don't worry about on the long term, like Afib. We sometimes will anticoagulate and forget about, but this is something we want to try and take care of because it will cause heart failure. Multifocal atrial tachycardia. I couldn't find a good picture of this, but if you can imagine an EKG with 3 distinct P waves on a regular 10-second rhythm strip, then you can picture just different parts of the atria acting as a pacemaker. And so each of these waves is coming through, and some of them are translating into ventricular rhythms and some are not. And so we get a irregular rhythm, much like in Afib. But this is usually found in COPD patients, and I don't know why. So if you do know, please leave a comment for me so I can understand that. But the treatment for it is verapamil and treating the underlying condition, which is usually COPD. So supraventricular tachycardia. Any of the ones that we've talked about so far actually could be classified as supraventricular tachycardia if they are tachycardic, because it's just any heart rhythm that originates above the ventricle. So to treat this, we're going to correct any electrolyte abnormalities that could be causing it, but vagal maneuvers are going to be one of the mainstays of treating it. These are going to be people who have these SVTs and can be taught how to do vagal maneuvers in order to break the SVT. And so that can include carotid massage or Valsalva maneuver, or also can be like getting in a bath of cold water or something like that. And if that's not going to work, then we can use adenosine, which I think is about 80% effective in breaking SVTs. And Vtach, this is when we start to get even scarier. The Vtachs are scary because they can progress to v-fib. So the Vtach is when we're going to have these extra beats, at least 3 of them in a 10-second rhythm, and this is going to be going on for more than 30 seconds is the technical definition of Vtach. So the treatment is amiodarone or lidocaine if these are asymptomatic patients, but if they are hypotensive or we can't find a pulse, then that's when we're going to defibrillate. Then vfib is the more serious step in this process, and this is when we've got a ventricular rate that is so fast that we don't get any ejection of blood, and really it's just a quivering heart. So what does it look like? Well, it looks like somebody dropping on the ground, and they lose their blood pressure. They don't have any pulse, and if you don't do anything about it, then they're basically dead. And the treatment for this is electric countershock. So you'll learn this in your ACLS class, but as we do the electric shock, and then we're going to be administering amiodarone or lidocaine as we do it, and then we'll wait and shock again. So I wanted to give a plug for this video. It's one of my favorite demonstrations of cardiac arrhythmias. If you just go to YouTube and search cardiac arrhythmias, there is a video here of a guy who does a great demonstration of how different arrhythmias look, and so you got to check that one out. All the images that I used here are either Creative Commons license or in the public domain. Here's where I found them all, and please comment below to help me make these better. The idea is to make this basically a online review course for step 2 and step 3 of the boards. So let me know if there's anything important that you think I left out, or any changes that I need to make note of, or any errors that I made. Thank you. I appreciate it.